Good morning, hello, and welcome to CHDY's, a special episode. My name is Rebecca Acosta, and I'm the Director of Education here at Conquering CHD. This episode is streaming live on our Facebook channel and will also be available for viewing later today at conqueringchd.org. As you may have seen on our social media platforms over the last month, Conquering CHD and Stanford have partnered on an educational campaign called What I Wish I Would Have Been Told About CHD. Today, I'm going to be joined by two Stanford physicians, and they are going to answer some of the questions you submitted during that campaign. Please join me in welcoming Dr. Anitra Romp, who is a cardiologist at the Adult Congenital Heart Disease Program at Stanford, which is a joint program between Stanford Children's Health and Stanford Healthcare. Dr. Richard Shaw is a child and adolescent psychiatrist at Stanford Children's Health. Thank you so much for joining us today. Let's get started. So, our first comment comes from a heart parent. She wishes her OB physician had done more to prepare her for having a baby with CHD. Dr. Romp, can you speak to the prenatal diagnosis process and what specialists should be involved?
Sure. If CHD is suspected, the mother is referred to a pediatric cardiologist to perform a fetal echo and counseling regarding the next steps. A fetal echo is a special ultrasound to evaluate the growing baby's heart. Depending on the severity of the diagnosis, the care team may grow to include not only the obstetrician and pediatric cardiologist, but additionally may involve a perinatologist, neonatologist, geneticist, and potentially a pediatric heart surgeon. Several situations may prompt the need for a fetal echo. For example, there may be a concerning finding in an ultrasound performed by the obstetrician, or there may be a concerning early blood test, a maternal history of diabetes, a family history of congenital heart disease, or an abnormal heart rate that is detected, just to name a few situations. Any of these situations would then necessitate the referral for a fetal echo.
Excuse me, I was muted. Thank you so much, Dr. Romp. Dr. Shaw, can you speak to what happens psychologically when parents receive a prenatal diagnosis? What can parents ask for during that prenatal period in terms of counseling or other support?
Yeah, hi everybody. Nice to speak with you today. The diagnosis of a cardiac condition in the prenatal period is an enormous shock for all families. We often describe it as a traumatic event, and it often triggers a number of symptoms that are very similar to post-traumatic stress disorder that we are familiar with more from the battlefield. And the types of symptoms that parents have often include intense anxiety, because the diagnosis is often a moving target. We don't actually know where it's going to end, and will there be a healthy child at the end of the pregnancy, or what treatment is going to be needed. Other psychological reactions that often we see in this context include feelings of guilt, parents blaming themselves or the other parent for the diagnosis, and it can create some very intense feelings both within the parents and, of course, huge anxiety that can continue throughout the pregnancy. Unfortunately, there are not a lot of interventions currently available for parents who receive a prenatal diagnosis. However, here at Lucile Packard Children's Hospital, we are actively aware of this issue and try to provide psychological support to families as they go through the process. And currently, we are actually working on a four-session intervention that we would offer to parents to help them process the trauma of the diagnosis, to provide them with more coping skills, to help manage their anxiety, and to prepare them for their child's birth and whatever else might be ahead.
Thank you for that. It's wonderful to hear that Stanford's working on that type of program. We also received many comments regarding mental health for parents. Some families state they received a little bit of information from their cardiac team, and others said they felt alone and lost, especially during and after hospital stays. Dr. Shaw, can you describe the mental health challenges parents of children with CHD face once they're born, and what resources are available to help them during those time periods?
Yes, in addition to the trauma of the diagnosis, there's often what we describe as a period of intense grief about the loss of what was expected to be a healthy child. And as I mentioned, the outcome being so uncertain. And the typical grief response can include initially feelings of anger or denial, intense anxiety, as I mentioned, and also quite severe symptoms of sadness and mourning as the parents try to take to take in the fact that they are not going to have the normal experience that they were expecting. So this often can create feelings of feeling alone. They have many friends, maybe have healthy siblings. They have feelings that this isn't fair. They don't know why this happened. And this can cause a lot of stress, both individually for the parents and in the couple. So it's really important for parents to talk about what's going on and to seek out help. And fortunately, there is certainly help and resources for families. So typically, things that can be useful would be to meet with the hospital social worker or psychiatrist. Child Life are really helpful in providing other support to families. And we have a wonderful parent mentoring program. And meeting with a family that has gone through this experience can be incredibly helpful for parents to help normalize the process and pick up tips on how to cope with it. And also to see that there can be a good outcome at the end of the whole process.
Absolutely. We also know that the patients with CHD experience mental health challenges. Dr. Romp, this one's for you. What are some of the obstacles that patients may face across their lifespan, and what do you usually say to your patients when they have these obstacles?
That's an excellent question. Thank you for letting us know about that question. As Dr. Shaw mentioned, patients may face the initial obstacles of shock and uncertainty around the diagnosis. There may be a greater degree of loss depending on when the diagnosis is made, for example, prenatal versus later in childhood or even adulthood. Children diagnosed early in life essentially grow up with CHD and may not know anything different, while those diagnosed later in childhood or early adulthood may similarly experience loss of previously feeling well and now having to face the new diagnosis with more awareness as they undergo treatment for their CHD. On par with developmental awareness may come anxiety or depression around upcoming medical visits, testing, or procedures. An adolescent or adult may have post-traumatic stress disorder, as Dr. Shaw mentioned, surrounding a test or a procedure where they previously, when they were younger, had no issues. Adults may have anxiety and depression, and these conditions may be heightened around the time of a visit, a change in clinical status, surgery, or hospitalization. While it is common for patients and families to undergo these periods of adjustment, we seek to support patients and families at every developmental stage. So for example, in childhood, we try to foster connections with other families, as Dr. Shaw mentioned, through camps and patient family days. Getting parents involved as parent mentors can give a sense of completeness, of giving back what he or she, what mother or father didn't have when they were going through that process. And these peer-to-peer connections actually exist on both sides, both at Lucile Packard Children's Hospital and Stanford Healthcare. And these peer-to-peer connections are very important. And ultimately, patients in the adult side can be part of patient family advocacy councils, where they meet regularly with both clinicians, care team, and patients to provide that liaison to continue to provide better care.
Absolutely. The Patient Family Advisory Council is one of the best inventions, I think. This next topic is something, Dr. Rumpf, I'm sure you're going to be familiar with. Several of our adult patients in the community commented they wish they had been told that CHD was a lifelong disease and that they would need special care for their lifetime. A few of these adult patients even noted they wish they knew that ACHD physicians even existed. So can you speak to the kind of patient education you provide in your clinic, and then how to combat some of the difficulties of remaining in care?
Yeah, great question. CHD is a lifelong disease, and we often say that patients are fixed but not cured. It's very important that patients and families understand that even though there may not be a procedure or a surgery associated with subsequent clinic visits, it's really important to continue with these visits. It's through these well visits, in fact, that we come to know each patient's baseline and help maximize their potential. They may require, for example, medication adjustments, or there may be periods of rapid growth, such as in adolescence, that can impact CHD. And the patients may need to be followed actually more closely. Through a team approach, we can help them also address coping with CHD, as Dr. Shaw mentioned, various school challenges, provide anticipatory guidance for dealing with CHD through college, trade school, and eventually a future career. At Stanford Children's Health, we began that transition education in the pre-adolescent to adolescent years. We provide transition education to empower patients to be active participants in their healthcare. The electronic medical record is also helpful in this regard, as phone apps bring the diagnosis, medications, and notes right at your fingertips. And as you know, our youth are very adept at using these phone-based apps. Armed with these skills from pediatric cardiologists, patients are then better able to advocate for themselves as young adults. Difficulties and challenges remaining in care not only include patient empowerment, but also include insurance barriers during times of transition off of parents' insurance to plans shifting to employer-based healthcare, especially if insurance is not offered through that employment. As you stated, the language used is very important, and we aim to teach that CHD is always a part of you and needs to be maintained over the long term. There may be periods of exacerbation that bring it more to light, and other times where CHD is more in the background to allow you to live your life.
Thank you so much for that, Dr. Romp. Continuing, I wanted to discuss how pediatric cardiology providers are ensuring their patients understand their CHD and how it'll affect their lives. What education is appropriate for parents, and when is it time to start addressing the patient themselves? And then what else can we do to ensure young adult patients are fully involved and aware of their condition and any related complications or co-diagnoses?
Thank you again for that question, very insightful. So each pediatric cardiologist and family can decide when the patient is developmentally appropriate to begin participating in care. Chronological age, as I mentioned, with pre-adolescent and adolescent is only one guide, and patients may vary depending on their level of individuation. The care team often draws pictures of CHD throughout childhood and adolescence, and can show patients and families the imaging, such as, for example, an echo or MRI, that may really emphasize certain aspects of the heart to both patient and family. Another important aspect is to involve patients and families, again, as I mentioned previously, in the portals of the electronic medical record, so that they may read visit notes, view reports and from the testing, and prepare questions for their providers for upcoming visits. In fact, preparing for the visit is one of the most important empowerment tools that patients and families can use. This often eases anxiety that may arise surrounding visits, knowing that the patient will spend some of that time in the driver's seat. And if it's not developmentally appropriate, at least the parent can subsume that role in the interim. And that just sort of helps bring that participation to more of a partnership in healthcare, such that both parties, both patient families and providers, are invested.
I love that you use the term partnership, because that's really what we're aiming for. I want to shift just a little bit to you, Dr. Shaw. Following up on what Dr. Romp has said, we know that parents of children with CHD are always advocating for their kiddos, whether it's in the clinic and school and family life, and that can be stressful, scary. For me, sometimes it's been intimidating. What's your best advice for parents as they navigate this CHD journey and advocating for their child?
Yeah, thanks for that question. I think there's a couple of things to say about this. First of all, having a child with CHD is not a sprint, it's a marathon. This is something that you're taking on for life. And I think Dr. Romp has been emphasizing the importance of development and different developmental phases. And each child, as they go through these phases, will have various issues that will be influenced by their CHD. And I think the challenge for parents is to really try to always keep focused on the concept of allowing their children to have the healthiest, most normal childhood possible. So one of the things that we have seen repeatedly in parents with children with CHD and other types of illnesses like cancer or premature infants, so there is a tendency to become very worried about your child and to be overprotective and sometimes to limit activities that maybe are developmentally normal. And a lot of this may come from the parents' worries and concerns that their child is somehow going to be harmed if they maybe engage in activities that most normal children should be able to do. We actually have a name for this. We call it the vulnerable child syndrome, where parents are in this pattern of being overprotective, which of course is well-meaning, but sometimes can work against the child's best interests. So I think at all times, if we think developmentally, for example, when you have a young child, a toddler, or someone about to start kindergarten, you want them to have sleepovers, you want them to have play dates, you want them to go to school. You want to encourage all of those things that are good for them. And sometimes parents have to kind of catch themselves and make sure that they are not allowing their own anxiety to intrude. Another time that can be particularly challenging is adolescence, where, of course, the teenager now wants to be more autonomous. They don't want to take their medications. They want to go out and take risks with alcohol or you name it, all the things that teenagers do. And again, if a parent is overprotective, they may try to inhibit these normal, impulses, and it's important for children to take risks. And this can create a lot of conflict within parents and families, and we've noticed this a lot. So I think it's really important for parents to be aware of these issues, to educate themselves, and if they find that they are having difficulties, to really seek out help in terms of counseling or meeting with a parent mentor to see how other families have handled these difficulties.
Absolutely. I have a few parent mentors in my life, and they have been instrumental as my two children are in the preteen era. So it's fun. So I want to pivot just a little bit and talk about some of the populations within the CHD community. One of the most active, especially here at Conquering CHD, is our bereaved families. At Conquering CHD, we have bereaved parents, siblings, and spouses that provide each other with support groups, resources, and most importantly, that peer-to-peer connection. Even so, families still report to us that managing the grief process is something they did on their own. So Dr. Shaw, can you speak a little, give some advice to families who have recently lost a loved one to CHD? And what are some of the resources that are available or that they can ask for in those situations?
Yeah, obviously losing a child is probably the most painful experience any person can go through. We're supposed to outlive our children, and when this gets turned on its head, it sets in process a train of emotional and psychological reactions that will probably continue lifelong. I think it's a time to reach out for help and to really try to think about the grieving process, to think about how it's affecting all of the members of the family, including siblings, and to really see this as a family trauma that is going to take time to process. There's no way to rush through grief. I think it's important to talk about what's going on, to kind of keep the child's memory alive. When you're meeting with friends, there's often going to be a hesitancy about bringing up the topic of your child that's died, but maybe letting them know that it's helpful to talk about this. You want to talk about it. You want to share memories. This is a way of healing. Um, Also paying attention to the relationship between the parents. When a child dies, this is incredibly stressful on their relationship, and there's often higher rates of divorce and marital conflict after the death of a child. So paying attention not only to your own grieving process, but what's going on with your partner. There are resources. Lucile Packard Children's Hospital has a wonderful bereavement program that's available at no cost for families. That you can get this information online and contact the bereavement program, and they will work with families, parents, children, siblings for over time to help them with the grieving process. And of course, it's also important to be always open to seeking out your own individual psychotherapy or couples therapy. Grief is a normal process, but there are times when it can become more than it needs to be. There can be really serious symptoms of depression, and sometimes medications are needed to help with mood symptoms or difficulty sleeping. So I think it's a time to feel open and entitled to seek out help and support from everybody in your community. And I think the parent mentoring programs can also play an enormous supportive role at these times.
Thank you. Dr. Romp, what has been your experience with bereavement in the adult CHD population? We know that so many more patients are living into adulthood and experiencing full lives, getting married and having their own families. What are some of the things you've come across with your adult patients in terms of bereavement?
Yeah, great question. So for the adult patients, we do have a cardiac behavioral health program, which consists of psychologists who are particularly focused on coping with all types of cardiac disease, not just CHD. We know that the impact of that on patients and families can happen well before anything untoward occurs to the patient. And those adjustments and that bringing forth, talking through those concerns are really important to do at every stage. In addition, we have a very strong palliative care program with a wealth of resources for patients and families. Most often, palliative care is associated with end-of-life types of discussions, but we seek to reframe that. Palliative care is really, just as the name sounds, to help you through difficult situations where things may be precarious, but may likely return back to normal. It's still important to involve their team. Our palliative care team is particularly focused on heart issues and can really help patients and families through this process, which may eventually involve the bereavement process, but they're supportive throughout the entire process.
Thank you. The last comment I wanted to address that was submitted during our campaign was sent in by a parent of a child with CHD. And they said they wish they had known that neurodevelopmental follow-up was recommended. And another parent along the same lines wrote they wish they had known what the term "may have some delays" really meant. So Dr. Romp, can you give us an idea of the big picture here? What are some of the neurodevelopmental or neurocognitive challenges that patients with CHD may face across the lifespan?
Absolutely. So children with CHD are at risk for neurodevelopmental morbidity, such as cognitive, language, and motor impairment, as well as possible behavioral problems. There's evidence to suggest that cognitive difficulties may persist into adulthood and have a psychosocial impact as well. Executive function, the topic of executive functioning can be most prominently displayed in things like planning, working memory, and processing speed. The factors influencing neurodevelopmental abnormalities are complex, and thus the role of neurocognitive testing as needed to support executive functioning is important to establish in childhood. Some patients, for example, may require an individualized educational plan or an IEP, and these supports may be carried into adulthood as tools. We continue to learn more about how comorbid conditions in adulthood, such as hypertension, diabetes, and coronary artery disease may continue to negatively impact executive function as well. Thus, this emphasizes the importance of lifelong follow-up so that we may support each patient fully from childhood to adulthood.
Excellent. Dr. Shaw, can you touch a little bit about how CHD may impact various milestones, specifically for children and then into the teenage years?
Sure, yeah. So I think Dr. Romp has already highlighted the neurodevelopmental outcomes that can be compromised, and this can lead to difficulties progressing academically. And I second her comments about seeking out support from the school district. But the other milestones that we focus on as psychiatrists and psychologists are the emotional milestones. Children have to go through various developmental phases as they grow up. These include becoming more autonomous, preparing for for high school, college, and leaving home. And I think one of the big things that we have seen sometimes is that having a CHD can really interfere with that process of separation, in part as that comes, as I mentioned earlier, from parents being somewhat overprotective. But teenagers and young adults also can lack the confidence and feeling that they are ready to take off and do things that they need to do in life. So I think it's really, really important for parents always to be focused on supporting their child's independence, encouraging them to take risks, and not allowing their own anxiety to interfere with the process of a child going off to college or work or whatever else it might be.
I'm going to remember your advice in a couple of years when I'm in that situation. Just checking the time here. It looks like we have time for one last question. So I wanted to just kind of turn it over to you, and in 30 seconds or so, what would you each like to share your final thoughts with patients and families today? Dr. Shaw, would you like to go first?
Yeah, I would say that having a child with CHD is it's a journey, and it can be a wonderful journey. We focus on some of the negative things, but you will have an amazing experience with your child, raising them and loving them, and they will love you, and they will achieve things maybe you never dreamed about. So I think it's important to keep this long-term perspective. There are going to be hard times, there's going to be surgeries, there's going to be setbacks, but keeping your eye on the big picture and the fact that things generally will work out okay. And along the way, make sure you ask for help. There's plenty of help out there, and you don't need to do this alone.
Excellent advice. Dr. Romp, what would you like to say to patients and families listening in?
Yes, I would echo those comments in that many times I spend time with patients and families talking about that this is something that has happened, right? It's not something that one asked for. But now how do we empower patients and families to take that forward, and what can you change about your life? What can you change and what can you do to live your life to the fullest? And just as Dr. Shaw mentioned, getting those resources, advocating for oneself and one's family, becoming involved such that this doesn't define you. Congenital heart disease doesn't define you, but rather is a unique aspect that provides you the resiliency to be able to go forward and live, literally live your best life, as the teens like to say.
I love it. As we close today, I really want to thank you both for sharing your expertise and your time and energy. I think this has been a wonderfully impactful campaign between our organizations. And anytime patients and families can come together and connect and provide that peer support, I think it's just a beautiful thing. So thank you both very, very much. And I'd like to share a touching comment that we received on the last day of the campaign from an adult who's living with CHD. She says, CHD is a life sentence of beautiful moments and fantastic achievements, but nevertheless lifelong. I have grieved the fact that there is no get to this point or this procedure or this age and then you're done path in the CHD journey, but nevertheless beautiful moments and fantastic achievements. So I'd like to leave you all with that thought. Thank you again for joining us, and be sure to review the entire campaign on our website and on our social media channels at conqueringchd.org. So thanks again. Until next time, please stay in care. Have a great day.
you.
Goodbye.